Good morning, everyone. Good afternoon, actually. Good noon. This is Margie Giuliano. I'm the Med Safety and ADE Regional Lead from the New England QIN-QIO, and thank you for joining us for today's webinar entitled An Insurer's Care Transition Program Emphasizes Medication Reconciliation, Reduces Readmissions and Costs. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I'll provide you instructions on how to ask questions at that time. Although the lines will be muted, we want you to actively participate in this session, so please share any med safety initiatives you're involved with in your facility and be sure to weigh in via chat. My colleague, Colleen Cordana, the Med Safety Program Coordinator in Massachusetts, will be monitoring and responding to chat during the session. So we'd really love to learn more about your efforts and how we might best support you going forward. Today's speakers have no conflicts of interest to disclose. Our learning objectives for this program are to recognize the association between adverse medication events and hospital readmissions, to identify the role pharmacists can play in providing med reconciliation-based programs to recently discharged patients, and to assess the implications of the current study for readmission prevention programs nationwide. As I shared during this call, we want you to use the chat feature so we get to hear from you, what you're doing, what you might need assistance with. So let's start by seeing who's on the call. Please type in your name, role, your organization, your state, and then participate via chat. I am now going to introduce our speaker, Jennifer Polinski. Jennifer is the Senior Director for Enterprise Evaluation and Public Health Analytics. Jennifer leads CVS Health's only company-wide strategic research team. We're very excited to have Jennifer present her work to us today. So Jennifer, I will pass the ball to you.
Thank you. My pleasure to be here, and thank you for inviting me. As Margie said, we'll talk today about a program that CVS did in partnership with a large nationwide insurer. So let me advance the slides here. Okay. So I'm probably going to tell you much information that you already aware of. That hospital readmissions, particularly those within 30 days of discharge, are quite common. Approximately 1 in 7 patients are readmitted within 30 days. And that results in about $41 billion in additional health costs per year. And there's been a substantial body of research to understand why that's the case and what factors are driving that high readmission rate. And we've seen that adverse drug events, whether they be drug-drug interactions, non-adherence, difficulties in filling medications, understanding which medications to take when, reconciling pre- and during hospital medications with post-discharge medications, etc. All of those combined are associated with up to 2/3 of readmissions. So they're a primary cause of those readmissions. Medication reconciliation programs have been around for a long time. And we've seen from the literature that these programs can result in significant reductions in these adverse drug events. However, it to date was unclear whether just reducing those adverse drug events would indeed reduce readmission rates. It's also unclear whether medication, or was unclear, whether medication reconciliation would reduce healthcare costs, given the investment you would have to make into such a program. The other barrier we faced as a company and a provider of healthcare is that much of the evidence is from academic teaching hospitals or integrated health systems. So if we take the academic teaching hospital lens, these are hospital-driven programs. So at discharge, hospitals are providing this service. And again, CVS is a broader insurer and a pharmaceutical benefits manager. We can work with hospitals, but we are also in touch with over 1,000 different hospitals, each of which has its own program. So we were very interested in seeing whether a program layered on top of whatever a hospital was otherwise doing would make an impact. The other piece is around integrated health systems. So the evidence there, those health systems are at a great advantage because they can see all of the care that a patient is getting as the patient moves from the hospital back to a primary care provider and to specialists. However, those integrated medical centers and academic medical centers only treat about 20% of the U.S. population. So clearly more information was needed. So that's the background and underpinnings of our study. So we were particularly interested, as I said, in looking at a commercial insurer-supported medication reconciliation program. And our two main outcomes that we wanted to investigate were 30-day readmission rates and net cost savings. So what's our return on investment? This was recently published earlier this year in Health Affairs. So here's the citation right here on the left-hand side if you're interested in learning more about the paper and the ins and outs. Okay, so let's move on to the methods that we used in the study. So members, here there are members in our pharmaceutical benefits management program and members of the insurer. These members were discharged in any time between June and November 2013. And we excluded patients who had a primary discharge diagnosis of malignant neoplasm because those folks obviously would be very different from patients who were otherwise discharged. Their healthcare trajectory would be different. The intervention itself was pharmacist-led. And so this is important because pharmacists here have a really great grasp of the clinical knowledge that they need to reconcile pre and post and even during inpatient drug regimens. They also provided education and support, really coaching and motivational support on the proper use and adherence to medications that the patient was taking. This could involve things like making sure that a person's pharmacy was aware of all of the medications the patient was supposed to be taking, and perhaps consolidating those fills, working with the insurer to consolidate the pickup dates. So let's say the patient had to fill 5 medications, the pharmacist could work with the insurer to make sure he or she could pick up those 5 medications on one day rather than having to go back to the pharmacy multiple times. It could also mean that the pharmacist, during the medication reconciliation, would reach out to the provider with questions and then get back to the patient. It could mean dose consolidation. So if a person had to take a drug multiple times a day and there was a simplified approach that would result in fewer doses per day, then the pharmacist would reach out to the provider and suggest that. There were two levels of intervention. So we used several identification algorithms that used age, gender, clinical complexity, history of hospitalizations, et cetera, to stratify members as highest risk of 30-day readmission and at moderate to high risk. The patients at highest risk received an in-home consultation. So the pharmacist went to their home and did the medication reconciliation there. For moderate high-risk members, the pharmacist performed the medication reconciliation in discussion with the patient on the telephone. And then all members, regardless of their risk level, received ongoing telephone support for 30 days. And on average, there were 3 additional calls during that 30 days. So the pharmacist could reach out to the patient could reach out back to the pharmacist. Okay. All right, so let's take a look at the study design. On the on the left-hand side, we have a 90-day baseline period. So that's when we're looking at things like a patient's pre-medication regimen, their clinical complexity, what kind of conditions do they have, how often are they picking up their medications, age, gender, other sociodemographics. Then the first vertical line is their admission date, and you see that baseline period is followed by the period of their hospitalization. And then we see the second vertical line is their discharge date, and that's followed by at least a 30-day follow-up period to see if they are readmitted. Importantly, pharmacists typically completed that medication reconciliation within 1 to 3 days after discharge. And we did not include patients in our analysis who were readmitted prior to the pharmacist reaching out to them. Okay, so the exposure, so here, members who received a program consultation were in our intervention group. And the control group were members who would have been study eligible, but lived in a region of the United States where the program was unavailable. So the program I'm speaking about now, members resided in southeastern states, so Alabama, Arkansas, Florida, etc., or the District of Columbia. So as a comparison control group, we selected members from the northeastern states and used them for comparison. Our outcomes, our primary outcome was all-cause readmission within 30 days. Our secondary outcome was looking at what that readmission was for. If they were readmitted, was it the same condition as the index hospitalization? Had they been discharged with a primary diagnosis of a cardiovascular condition and or respiratory condition? And then finally, we looked at the return on investment. So here you can think about that as cost savings for each $1 we spent and devoted to the program. Okay, confounding adjustments. So as you might imagine, there are certain factors about the patient, about the hospital, about their condition that are going to impact whether or not they're readmitted at 30 days. And when that, those factors are related to both being eligible for the medication reconciliation program itself and related to whether or not they're going to be readmitted at 30 days, that's a confounder. And so we want to adjust for these confounders and make sure that to the largest extent possible that those confounders are balanced between our intervention and control groups. So what we did was we used something called propensity score matching. Essentially, it looks at patients' propensity or likelihood of being in the intervention group versus the control. And it includes all of the factors or covariates you see listed here. So at the individual level, we had many demographics and many clinical variables. And at the zip code level, we had measures of socioeconomic status. And given that person's probability or propensity to be in the medication reconciliation program, we matched intervention to control patients. So you might imagine that within that pair match, those two patients have a very similar, if not equal, likelihood of being in the medication reconciliation program. There were 3 intervention patients who could not be matched to a control. You can think of those as the outliers of really extreme cases, and those were excluded. Okay. So our analyses, we looked at baseline descriptive characteristics. So in the 90 days prior to that person's hospitalization, we looked at their descriptives. And by descriptives, you'll see, I mean age, gender, clinical complexity, etc. We compared intervention versus their matched controls. And we also looked at, let's look at our high risk or highest risk members who receive the program in-home and see how their characteristics compare to those receiving telephone consultations. For our 30-day readmissions outcome, we looked at absolute risks. And so this is an additive measure. So we're comparing the proportion of patients or percent of patients who had 30-day readmissions between the intervention group and the control group, and we're subtracting those. So it's on an additive adding subtraction scale. We also looked at risk differences, which adjusts for all of those covariates and confounders I mentioned before. And then we looked at risk ratios, which are multiplications. So it's literally the intervention group's risk of readmission divided by the control group's risk. And so we'll go over those as well when we get to the results. Given that this was a 2013 study, we looked at the nationwide costs of a readmission event, a 30-day readmission event, and those are published estimates from the Healthcare Utilization Project, which is a survey and data collection project from the Agency for Healthcare Research and Quality. And finally, we looked at the program's cost itself, and we knew those, of course, because we implemented the program. And that was a weighted average of the in-home and telephone costs. Okay. All right, so the moment you've all been waiting for, the results. This is the most exciting part, I promise. So here you get a sense of what patients' characteristics were before they were hospitalized. And here we have 131 intervention group patients and a matched 131 control group members. The really nice thing you'll see here, and this is an attribute of the propensity score approach we use, is most of the measures maybe I shouldn't put that yet. I'm giving you the punchline. Most of the characteristics were quite balanced across the group. So, for example, age, which is the first row, average age was about 62 in the intervention group and about 61 in the control group. The one characteristic that remained out of balance were the hospitalizations prior to their index hospitalization. And so you can see in the intervention group, 15% were hospitalized in the 30 days prior to their index, whereas about 7% in the control group. Similar imbalance for 90 days prior to the index hospitalization. So we additionally controlled for this in our analysis. And importantly, this would also bias our results. Let's say we weren't able to adjust for this. It would make our intervention group harder to prevent 30-day readmissions in because they had evidence of repeated admissions. So if it's harder to move the needle on those 30-day readmissions, it's more likely that we're not going to see a difference that we can attribute to the medication reconciliation program. Okay. So now this table, or this slide, compares patients who received an in-home consultation, there were 54 of those, to those who received a telephone consultation. And as we might expect, they are more likely to have hospitalizations in the 30 days prior or 30 days prior to their index. Those are at the highest risk. They're more likely to have an index hospitalization for a cardiovascular condition. And importantly, they're more likely to be female and to be older. They're also taking, at the very bottom, an average 5 medications versus our telephone consultation folks taking on average 4 medications. Okay. All right. So let's take a look at readmission risk at 30 days. Now, there's a lot of information on this slide, so I'll take some time to orient you to it. So the leftmost column are the different outcomes we're looking at. And let's take the additional columns piece by piece. So intervention group risk is the proportion of patients, or percent of patients, who are readmitted at 30 days in the intervention group. So for readmissions at 30 days for any reason, 12.2% of the intervention group was readmitted. 6.9% of those were readmitted for the same condition as their index hospitalization. Then you see 5.3% cardiovascular condition, and 1.5% the index hospitalization was respiratory in nature. In the middle column, you can see the comparison with the control group. So in comparison, 22.1% of control group members were readmitted for any cause within 30 days of their discharge date. And then in the following 3 rows, you see how that broke down, what percentage were readmitted with the same condition, with a cardiovascular condition, or with respiratory. Moving along to the right, to the risk difference column. So as I mentioned before, this is subtracting the 2 groups. So here we're subtracting the intervention group's risk from the control group's risk, and we see that they had an 11.1 percentage point reduced risk of all-cause all-cause readmission at 30 days. And that varied in, if you think about, well, what's the error around that, varied from 2.3% less to 19.9% less. And because that interval there does not cross 0, which would indicate that they're equal, that's considered a significant difference. So the main takeaway there is that the intervention group patients, 11% fewer patients in the intervention group were readmitted within 30 days. Okay? If we move over to the risk ratio, now we're comparing the intervention group divided by the control group risk. And so adjusted, the intervention group had a 50% reduced risk of 30-day readmission as compared to the control group. And here you'll see that's significant as well. Okay, so it's really just two different ways to look at the same data. Okay, all right. Let's look at our return on investment. So the program cost per person was $677, and these are in 2013 dollars. Keep that in mind. We had 131 interventions in our intervention group. You saw from the previous slide the change in the readmission rate, 11% fewer patients, 11% less, and then the average cost per readmission from the HCUP was roughly $13,500. And when we compare that, so the benefit, the cost savings, relative to the cost of having the program is 1.99. So a 2-to-1 benefit to cost ratio. And then the cost savings per person was approximately $1,300. So this was quite valuable, substantial savings here. And of note, the average cost per readmission definitely varies depending on where you are in the country. So you would see, higher average cost per readmission as well as lower depending where you are. Okay, so let's discuss some of these results, and I think this is where I am really interested in hearing your questions and feedback as we wrap up the presentation. So to sum up, the Insurer-supported medication reconciliation program had a reduction in 30-day readmissions, reduced those by 50%, and a savings of $2 for every $1 spent on the program. So as we see it, the success likely depended on several key factors. We had an algorithm that we used to identify members at moderate to high or highest risk. That algorithm included demographics, measures of clinical complexity and past medical use, as well as some measures of socioeconomic status. We were able to perform successful outreach and enrollment of members. And this can be one of the hardest barriers to prevent 30-day readmissions, in that once that discharge occurs to the community, it can be tough to maintain contact with those patients. So our successful outreach was very key to driving our results. Thirdly, as I mentioned before, the initial consultation was within 3 days of discharge. So we want to offer support and these services as soon as possible post-discharge. And then after that, we offered these 30 days of follow-up support. So recognizing that not everything is going to be resolved in one in-home visit or one telephone call, we offered at least a month of support. And as I noted before, both patients and pharmacists took advantage of that, and the average number of calls during that 1 month was 3. Finally, we matched the intensity of the program to the members' level of need. So the highest risk members, of course, got the in-home consultations, much more expensive than the telephone consultations. And so by matching that intensity to the risk, we were able to maximize our impact, but at the same time manage our costs. Okay. All right. So how does this relate to a broader policy and more important for you all, I think, is how do we translate this into practice? So readmission prevention is and has been in the spotlight. Both public and private payers have focused increasing attention on this phenomenon and are using this in quality performance measures, financial incentives, and or penalties. Our program, we feel, offers real-world applicability. So, and here's 3 key reasons why. As I mentioned before, only 20% of patients receive their care in academic teaching hospitals or integrated health systems like a Kaiser. So the majority of Americans are in a disjointed and not poorly connected, but less than ideal connected healthcare system where all of their providers and all of their provider locations can see the totality of their care. So our successful program was successful because it capitalized on flexible implementation. So we layered this on top of whatever initiatives hospitals, providers, other organizations were doing to prevent 30-day readmissions. And because we were able to layer that on, we were really agnostic as to those programs and could do our outreach to all of these patients. And then finally, we capitalized on what we know are the really unique and really meaningful skills and thoughtfulness and ability to interact with patients that pharmacists possess. And having a pharmacist lead these medication reconciliation sessions, both in-home and via the phone, we think is highly generalizable to many settings, whether it be an insurer or, frankly, a QIN-QIO setting. And of course, CVS, as a pharmacy company or as a healthcare company, we value our pharmacists very much. And so we thought they were uniquely positioned to implement this program. Okay, so like I said, work was recently published in Health Affairs. If you'd like more information, I'd encourage you to see it there. Thanks so much, and very happy to take questions.
Thank you, Jennifer. So I think we're ready for some questions. You can either submit via chat or even better, open your phone line to share. Morgan, can you let the participants know how to open their phone lines? And while we wait, Colleen, do we have any questions or comments in chat?
So to unmute your line, you will press #6. Again, you'll press #6, but while we wait for folks to figure that out, Colleen, do you see any questions?
Let me see. Not currently. Let's see. Charlotte, Chris said, what did the 30-day follow-up look like, and how was it communicated to the participant patient?
I'm not sure I follow on the question. So during the 30-day follow-up, maybe I'll start here, and then if this is not what you were interested in, please feel free to ask again. So
yeah, we have another question. Oh, go ahead.
Can you speak about the process of getting commercial insured to support your program? So would you prefer I answer that one first, or?
Actually, why don't we go in order, and then Charlotte can chat in if she wants to clarify. Lucy asked what was the criteria used for the in-home visits for the high-risk patients.
Glad you asked that. Yeah, hard to fit on slides, but happy to answer that. So higher risk, the highest risk who received the in-home consultations, they had to use at least 7 medications, or they used at least 5 medications and had what we considered a very readmission sensitive condition. So that would be congestive heart failure, chronic obstructive pulmonary disease or asthma, discharge for pneumonia, diabetes, end-stage renal disease, some of the mental health conditions, schizophrenia or bipolar disorder, or had a history of falls that have brought them to the hospital. And then I'll also say the members at moderate to high risk, so those you might imagine were a step down for the telephone calls, those folks either used 5 or 6 medications and had none of the sensitive conditions I described, or they used 3 or 4 medications and did have one of the sensitive conditions I described. Okay.
Great, thank you. The next question was Charlotte, and again it says, what did the 30-day follow-up look like, and how was it communicated to the participant patient?
Right. Okay. So again, I'm not sure what that one is getting at, but I'll try. So within the 30 days, they had ongoing telephone support. So what that meant was 24/7 they had access to a pharmacist-led telephone line. Patients could call in with any questions they had, and the pharmacist on call would take that question, answer it, and put it in the person's record, or if it needed action for follow-up, send it to the pharmacist who the patient had been working with. On the other side, a pharmacist could reach out to the patient, and the pharmacist might reach out to say, hi, I talked with your provider about simplifying your dosing schedule. Here's what we worked out, and here are the next steps. Or I was able to schedule you a visit with your provider based on what we discussed about side effects with your medication. Here's the information on that. It was presented to patients as an opportunity and an option they had, but not a requirement of the intervention. So hopefully that helps.
Thank you. Our next question is if you could speak about the process of getting a commercial insurer to support the program.
Good question. I think every commercial insurer is going to be unique. One of the things that we were able to really work in collaboration with our insurer is that we had an established relationship with them as the pharmacy benefits manager for the insurer. And so we already had an established collaboration with them, a track record of helping and supporting their patients in taking medications as prescribed, improving adherence, avoiding drug-drug interactions, etc. And so we were able to present this as an opportunity to enhance that collaboration and really take it to the next level to see what impact we could have on medical outcomes.
Perfect, thank you. Alejandro wants to know what kind of index diagnosis was the intervention statistically significant in reducing risk?
Good question. Let me go back to that slide. Okay. So we looked at 3 flavors, if you will, of the readmission risk. And keep in mind that we had 262 patients in total in the evaluation, and that meant only a certain percent of them were readmitted. And so we have relatively small numbers to be able to detect a statistically significant difference by condition. In fact, when we looked at, if you look at the second or third row of this table, same condition as indexed hospitalization, you'll see that neither difference neither measure, the risk difference or the risk ratio, the risk difference nor the risk ratio were actually statistically significant. And the same goes for if the index hospitalization was a cardiovascular condition or if it was a respiratory condition. We just don't see significance there. We believe that's just a lack of power, lack of numbers to detect that difference.
Perfect, thank you. As of now, that's all the questions that are in the chat. Does anyone else have any other questions, or are there any comments? Oh, we do have one from Jeff Lowe. He said, of the eligible patients, what percent agreed to participate? Was it 70%? How many covered lives were a part of this study?
Yeah, that's a great question. So I don't have the what percent, how many covered lives. I will say this is a large nationwide insurer. So of the eligible members for the program, either they were identified at highest risk or moderate to high risk, approximately 15% of them could not be contacted at all. And 11% of those who were contacted declined to participate. And when we asked them why, what is the reason you're declining, roughly half of them said, well, the program won't be useful. And 27% said that they had other services that would meet the same needs, so they were duplicative services.
Thank you. Scott asked how many hours or FTEs were required to manage the 131 patients for consultation and documentation?
That's a good question as well. Let me look that up while I'm talking to you. So I don't see it immediately available in my notes. One way we could back that out, I suppose, is looking at the cost of the program itself, which was $677 per member. You might imagine that the medication reconciliation initial consultation was several hours, both with the preparation, or excuse me, not both, but with preparation, the actual consultation, and then follow-up and documentation. I would have to get the exact numbers to you.
Okay, great. Thank you. There are no more questions right now in the chat box. If you have a question, please chat in. Comments are welcome as well. And a couple of people asked about when the slides would be available. Margie just posted our website, and the slides are available there now, so you can download and print those. We'll also have a link out.
Sorry, I didn't mean to cut you off. I was going to say, if you have a question you wanted to ask via the phone, press #6 to unmute your line.
If there's any comments, anyone doing some work?
Colleen, was that
Yeah, that was repeating on the phone. Let me go ahead and mute that.
Colleen, do you want to...
Hi, it's me. Hi, it's me. Can you guys hear me?
Yeah, but we're still here in the background.
Jen, was there anything else?
There are no other comments that I have. I'm afraid I am at this point. But happy to come up that. Hello?
Hello?
I just tried muting all participants again to see if it helped this time. Jen, if you want to press #6, Jen, are you still there?
I am.
Okay. Success. So let's get back to questions and answers.
All right.
Great. Can you guys hear me?
Yes, we can.
Okay, perfect. So the last question is the insurer and hospital willing to pay for continuation of the service based on the outcome of this study?
So, yes, in this case, we did continue to work with the insurer and refine the intervention itself based on some of the things we learned about the highest risk patients and those consultations from moderate to high risk. So we're still working with that insurer, and we continue to work with other insurers. This is not the only one. It just happens to be the first one we did, as well as other healthcare systems to talk about this kind of collaboration.
Okay, thank you. Someone asked if the event was eligible for CE credit or RPHs, this event.
Yes, we do have ACPE accreditation, and we will give you the code in just a minute as we wrap up. So all pharmacists who fill out the evaluation will be able to get ACPE credit for this program. Do we have any other questions, either via chat or if we want to try on the phone?
We do have one from Sandra. She's asked to what extent were pharmacists involved in the readmission process where new medication reconciliations performed to try to find out if readmission was a result of the patient's medication regimen?
That's a great question, Sandra. I am not familiar with that part of the program. And what happened if a patient was readmitted. I can ask the program brains, if you will, behind the program and see what that looked like.
Thank you. Are there any other questions? Feel free to chat in or unmute yourself.
Any other questions out there? Anyone want to try the phone?
It's #6 to unmute your line. I know it scares us all now.
We do have a question from another Colleen. She asked, were the same pharmacists going into the home and conducting the telephonic follow-up?
Yes, it could be.
Great.
We'll give it one more minute in case anybody has any follow-up questions.
Or would like to share anything similar that you're doing at your own organization.
Well, Jennifer, I want to say thank you so much for the presentation. It's very exciting, especially, for the pharmacists on the call. I think it's great. It's definitely real life, research, and, I think that's definitely valuable for us. Right now we have on our screen the schedule of our future lunch and learns. So in January, we're going to take a deeper dive into managing chronic pain. We're going to have Michelle Matthews from Massachusetts, who will present on breaking the back of the beast, improving outcomes in chronic pain management through commonsensical opioid use. And then later in January, we're going to have a panel discussion, which will have featured Connecticut's Director of Drug Control, Roderick Marriott, who oversees the Prescription Drug Monitoring Program, and we'll also hear from two clinicians who use the tool. So save the dates for that. And as you see, we have a program in March on antibiotic stewardship, and we'll do a deeper dive into anticoags in May, and then in July we'll be looking at diabetes. So our code for the program today is reconciliation. So for pharmacists who are looking for ACPE credit, again, make sure that you fill out the evaluation and include the ACPE code for that program. Now on the screen, I just wanted to share with you contact for your med safety lead in each of the states. If you have some initiatives that you're undertaking and you'd like to share that, please feel free to reach out to us. However we can help you, we're more than willing to help. So thank you again for attending today's webinar, and I wish you all have a wonderful holiday season. Morgan?
Yeah, as you guys close out of the webinar, the evaluation will automatically pop up on your screen. If you could fill that out, we'd greatly appreciate it. As Margie mentioned, there's a space in there to put the code to make sure you get your credit for this webinar. The PowerPoint presentation is located on our event website. I did put that link in chat. But again, it will be in the email you'll receive tomorrow, which will include that link as well as the evaluation should you not have time to fill that out today. I wanted to let you know that the New England QIN-QIO is now on social media. You can find us on LinkedIn and Facebook, so be sure to check us out and see any of the other upcoming events that we have going on. And as Margie mentioned, our next webinar is on January 10th, so be on the lookout for emails about that. And thanks again, Jen, for a great presentation, and thank you for bearing with us during some minor technology issues, but everyone have a great day.